about oral cavity. The important 10-mark question asked on the oral cavity topics are carcinoma of buccal mucosa and carcinoma of tongue. The important 5-mark questions are leukoplakia, pre-malignant conditions of oral cavity. And also, I will be covering 3 topics under oral cavity, that is pre-malignant condition, carcinoma of buccal mucosa, and carcinoma of tongue. The remaining very important 3-mark question, ranula, I will not be covering. I urge you to go through it after the class. Now let's start with pre-malignant lesions of oral cavity. The pre-malignant lesions of oral cavity are categorized into 3 groups based on the risk of transformation to malignancy. Those are high risk, medium risk, and low risk. The high risk pre-malignant conditions of oral cavity are leukoplakia, erythroplakia, and chronic hyperplastic candidiasis. The medium risk conditions are oral submucosal fibrosis, syphilitic glossitis, and Plummer-Wilson syndrome. The low risk group are oral lichen planus and discoid lupus erythematosus. Let's first discuss about leukoplakia. Leukoplakia is an hyperkeratotic white patch seen in oral cavity with no clinical and pathological evidence of any other disease causing this white patch. So here you can see the white patch, tough white patch, which is hyperkeratotic, and it is adherent to the underlying structure. Now, what are the types of leukoplakia? It is divided into homogeneous type, non-homogeneous type, and speckled leukoplakia. The homogeneous type are where we see uniform white patch. In non-homogeneous type, we see fine nodular like lesions. In speckled leukoplakia type, along with fine nodular lesions, we see atrophic erythematous base. This is the types of leukoplakia. The risk of malignancy will increase as we go from homogeneous to speckled leukoplakia type. We have one variant of speckled leukoplakia type called as proliferative verrucous speckled leukoplakia, where this proliferative verrucous type has high risk of malignancy. Around 85% of them undergoes malignancy, and also is most commonly seen in elderly population. Now, what are the clinical manifestations of leukoplakia? Before that, what is the idiopathophysiology of this condition? Chewing pan and smoking has been associated with leukoplakia. The leukoplakia is most common in males due to this reason. What are the clinical manifestations? We see whitish or grayish patch, which is adherent to underlying structure, and the patch is hard and indurated. And please note, the lesion is not painful. There is no pain associated with this lesion. And the lesion can be multifocal. The lesion we usually see in cheeks, tongues, and gums. Now, how to manage this condition? We have investigation and treatment. When we take biopsy of the lesion, that is white patch, we see parakeratosis, that is nucleated cells within the stratum corneum layer, and widening of the rete ridges. The epithelial projections will be widened. You can see here. Now, how to treat this leukoplakia? Stop smoking or eating pan, chewing pan, and then we perform surgical excision of the lesion with or without skin grafting. And also we can use CO2 laser for excision of this lesion. So tretinoin usage has been found helpful in case of leukoplakia. This is about leukoplakia, which has around 4 to 10% risk of malignancy. We have other condition called as erythroplakia. The risk of malignancy in erythroplakia is 17 to 20 times more compared to that of leukoplakia. More than 50% of erythroplakia lesions goes into malignancy. Now, what is this erythroplakia? Erythroplakia is a red, velvety, smooth lesion. No other disease is causing it, meaning we can't attribute this lesion to any other disease. It is a lesion caused due to chewing pan, smoking, etc., due to the risk factors which causes dysplasia. This is erythroplakia. The lesion is red and velvety because the stratum corneum layer here is thin, in contrast to leukoplakia where it is thick. So due to the thin stratum corneum, the submucosal blood vessels will be clearly visible, which manifests as a red lesion. If we see leukoplakia along with erythroplakia, we call it erythroleukoplakia. Now, how to manage erythroplakia? Erythroplakia is managed by, first we will perform biopsy where we see parakeratosis similar to leukoplakia, and then we also see epithelial dysplasia, superficial epithelial dysplasia. We don't see dysplasia in case of leukoplakia, but in erythroplakia we can see dysplasia, that is altered shell nucleus to cytoplasm ratio, atypical nucleus, etc., and mitotic bodies. And the management is will surgically excise this lesion. Now let's see what is chronic hyperplastic candidiasis. Chronic hyperplastic candidiasis is seen in immunodeficient individuals due to infection of Candida albicans involving buccal mucosa. The lesions usually occurs at the commissures of mouth and tongue, that is the junction of upper lip and lower lip, and in the commissure of tongue. We see curdy white patches in chronic hyperplastic candidiasis. You can see curdy white patch. The treatment of this condition is we can use topical or systemic antifungal, or else we can do surgical excision. We can also use laser for excising this lesion. This all the high risk pre-malignant conditions. What are the medium risk pre-malignant conditions? In medium risk pre-malignant conditions, we have oral submucosal fibrosis, syphilitic glossitis, and Plummer-Vinson syndrome. The oral submucosal fibrosis has a risk of 4.5 to 7.6% to turn into malignancy. What is the etiopathophysiology of this condition? If the patient is hypersensitive to chili, to betel nut or arecanut or tobacco, on chewing these substances or consuming chili, the patient immune cells mount as response against these antigens, so thereby causing hypersensitivity reaction followed by inflammatory response and fibrosis in the submucosa, causing oral submucosal fibrosis. And also vitamin B complex deficiency has been associated with oral submucosal fibrosis. The clinical manifestations are due to submucosal fibrosis, which called as trismus, that is inability to open the mouth, and also ankyloglossia, that is inability to protrude the tongue due to fibrosis. How do we manage this condition? We manage this condition by avoiding the substance which is causing hypersensitivity reaction, and also we can give local injections, submucosal local injection of 4 milligram dexamethasone along with hyaluronidase. Dexamethasone suppresses the inflammation. Hyaluronidase will break down the fibrotic band which has already been formed. These two substances we give bi-weekly. The submucosal injections we give bi-weekly for 10 weeks. If it is resistant to the treatment, we can surgically excise this lesion, followed by covering of the excised lesion by skin graft or tongue flap. This is about oral submucosal fibrosis. We have other medium risk conditions like syphilitic glossitis and Plummer-Vinson syndrome. Plummer-Vinson syndrome is characterized by triad of dysphagia, iron deficiency, anemia, and esophageal web. What are the low risk conditions which can lead on to oral cancer? Those are discoid lupus erythematosus associated with SLE and oral lichen planus. So to summarize, the pre-malignant conditions of oral cavity are high risk, medium risk, and low risk. High risk ones are leukoplakia, erythroplakia, chronic hyperplastic candidiasis. In leukoplakia, we see hyperkeratotic white patch without any cause, clinical or pathological disease which can be identified. The etiopathophysiciology are chewing pan and smoking, which causes white or grayish patch which is hard and indurated. This can be multifocal, seen in cheek, tongue, and gums. The management of this condition are we take biopsy. Biopsy we see parakeratosis and widening of retinal ridges. The treatment we have stop smoking or chewing pan, and we can excise it surgically with or without skin grafting. The types of leukoplakia are homogeneous, non-homogeneous, and speckled leukoplakia with risk of malignancy increasing from homogeneous to speckled leukoplakia type. We have erythroplakia. Erythroplakia is a condition where we see red velvety lesion, which is not due to any other diseases. It has more than 50% to undergo malignant transformation. If we see erythroplakia along with leukoplakia, it's called erythroleukoplakia. The management is we take biopsy where we see dysplasia in erythroplakia, and also we see parakeratosis, and we'll surgically excise the lesion. The chronic hyperplastic candidiasis is white curdy patches seen in immunotherapy deficiency in individuals infected with Candida albicans. Treatment is topical or systemic antifungal with surgical excision or laser therapy. We have medium risk oral submucosal fibrosis. Oral submucosal fibrosis is caused by hypersensitivity reaction to chili, betel nut, or tobacco, causing inflammatory response, which leads to submucosal fibrosis, causing trismus and ankyloglossus. We treat this by giving submucosal injection of 4 mg dexamethasone and hyaluronidase injection biweekly for 10 weeks. If it is resistant, we do surgical excision followed by skin grafting or tongue flap placement. Then we saw Plummer-Vinson syndrome, where we see triad of esophageal web, dysphagia, and iron deficiency anemia. The low risk lesions are oral lichen planus and discoid lupus erythematosus. By this, we are ending discussion on pre-malignant lesions of oral cavity. The buccal carcinoma of buccal mucosa. The carcinoma of buccal mucosa, most commonly we see squamous cell carcinoma, followed by adenocarcinoma and melanoma, which are rare. The adenocarcinoma can arise from minor salivary glands or mucus secreting glands. What is the etiopathophysiology of this condition, that is carcinoma of buccal mucosa? We have many risk factors, that is alcohol consumption and smoking. Chewing betel nut or arecanut has been associated with increased incidence of buccal mucosa carcinoma, where this arecolin causes collagen synthesis, increased collagen synthesis, and stimulation of fibroblasts, which causes submucosal fibrosis, which we already seen. This is a pre-malignant condition. Then chewing slaked lime or sunna will cause buccal carcinoma. Also, the tobacco has the highest risk in causing buccal carcinoma, carcinoma of buccal mucosa. The pre-malignant conditions like chronic candidal hyperplasia, and then leukoplakia, erythroplakia, Plummer-Vinson syndrome, and then we saw other submucosal fibrosis. All these conditions are associated risk factors for carcinoma of buccal mucosa. What are the sites where we see buccal mucosa carcinoma? We see commonly in cheek region, followed by tongue, followed by floor of mouth, palate, and lips. What are the clinical manifestations that we see in buccal mucosa carcinoma? The primary lesion, we have initially painless ulcer, which is gradually increasing in size. Painless ulcer, gradually increasing in size. The ulcer is having everted edges with indurated base, and the ulcer is non-tender on palpation. You can see the lesion, everted edges, indurated base, and it is non-tender. If the patient has pain, it suggests the infiltration of the ulcer, the carcinoma, into the skin, or it suggests the involvement of mandible, extension to mandible, or the patient may also present with referred pain to ear due to involvement of lingual nerve. We know lingual nerve and auriculotemporal nerve are the branches of trigeminal nerve. So involvement of lingual nerve through the auriculotemporal nerve causes the referred otalgia. The patient also complains of halitosis, that is bad breath, secondary to necrosis of this painless lesion ulcer. After necrosis, the lesion due to release of ammonia, butyric acid, and mercaptan, there will be halitosis, that is bad breath. If the ulcer is seen in retromolar trigone area, it suggests advanced disease. Why? Because from retromolar trigone area, the lymphatic will spread to pharyngeal lymphatics. Through pharyngeal lymphatics, The carcinoma can reach retropharyngeal lymph nodes, which is a sign of advanced disease. Now we have spread of this lesion. It can spread to, it can have direct extension and lymphatic spread. Direct extension, we have extension to mandible. On bidigital palpation of mandible, we see thickening, tenderness, and pathological fracture. It suggests direct extension to mandible. If the central part of mandible is involved, along with the pouting of the lower lip, there will be drooling of saliva. This is called as anti-gump deformity. The direct extension may also extend to maxilla, causing the swelling visible outside with the ulcer inside the oral cavity. The carcinoma can also involve pterygoid muscles, causing trismus. Under lymphatic spread, we have spread to submandibular lymph nodes and upper deep cervical lymph nodes, that is 1A and 2, lymph node group 1A and 2. The lymph nodes are initially mobile, followed by fixity of the lymph nodes to the surrounding structure. They become hard and fixed. These lymph nodes can extend after being fixed. The carcinoma from the lymph nodes can spread to surrounding 12th nerve, that is hypoglossal nerve, causing hypoglossal nerve palsy and deviation of tongue to the same side. It may involve accessory spinal nerve, causing impaired shrugging of shoulder. It may involve cervical sympathetic ganglion, causing Horner syndrome. This is about the primary lesion and spread of the buccal mucosa carcinoma. Okay, what are the features of advanced carcinoma cheek? Involvement of retromolar trigon, as I already told, is a feature of advanced disease. Extension into base of skull and pharynx, it's obviously the feature of advanced carcinoma. The fixed neck lymph nodes and extension to opposite side is a feature of advanced disease. Extension to opposite side meaning the lesion here has spread to opposite side. Now, how do we manage this condition, that is buccal carcinoma? First, we do incisional biopsy, that is edge or wedge biopsy. On doing wedge biopsy, we take the biopsy from the edge, not from the center, because center there will be only the necrotic material. When we do wedge biopsy, we can see keratin pearls along with atypical cells, which confirms the diagnosis of squamous cell carcinoma involving buccal mucosa. For staging purpose, we do FNSE of lymph nodes, where we can see lymph nodes spread to lymph nodes. We do CT and MRI to see local extent of the disease. For confirming mandibular involvement, we do orthopantogram. It's an X-ray where we can see involvement of mandible. Next, let's proceed on to discuss about TNM staging. Under TNM staging, we have tumor, nodal, and metastatic staging. Under T staging, please only remember 3 to 4 numbers. That is 2 centimeter, 4 centimeter, 5 mm, and 10 mm. That's all what is required. We can get T1, T2, and T3. In T1 disease, the size of the lesion is less than 2 centimeter, less than or equal to 2 centimeter, with the depth of invasion being less than 5 mm. In T2 disease, the size of lesion is less than or equal to 2 centimeter, with the depth of invasion being between 5 to 10 mm. If the tumor size is between 2 to 4 centimeter, here we saw if it is less than 2 centimeter with depth of invasion more than 5 mm up to 10 mm, it is T2. Or if the tumor size is between 2 to 4 centimeter with depth of invasion less than 10 mm, it also comes under T2 disease. The T3 disease is the tumor size more than 4 centimeter and depth of invasion more than 10 mm. Now, what is T4 disease? T4 disease is spread to adjacent structures, which we already saw. Spread to adjacent structure. T4A is the tumor can be resectable. In T4B, we can't resect a tumor, we only give palliative therapy. Coming to nodal staging, we have to remember only two numbers, that's it. That is 3 and 6. No nodal involvement is N0. N1 is single ipsilateral lymph node involvement with the lymph node size less than or equal to 3 centimeter. N2 is further classified into N2A, N2B, and N3, N2C, where N2A is single ipsilateral lymph nodes with tumor size between 3 to 6 centimeter. Sorry, with lymph node size between 3 to 6 centimeter. N2B is multiple ipsilateral lymph nodes. From 2B, multiple lymph nodes starts. Multiple ipsilateral lymph nodes with the nodal size being less than or equal to 6 centimeter. N3 disease is the involvement of contralateral lymph nodes along with the lymph node size less than 6 centimeter. If the lymph node size is more than 6 centimeter, whether it is single, unilateral, ipsilateral, contralateral, it's come to the N3A. If there is extra nodal extension, meaning the tumor cells has gone beyond the lymph node capsules, it is classified under N3B. Metastasis M classification, we have M0, M1, where in M0 we don't see distant metastasis. In M1 we see distant metastasis. Now we saw the investigation and staging of buccal mucosa carcinoma. Let's see the treatment of buccal mucosa carcinoma. First, let's see the procedures, what the modalities, treatment modalities, what that can be offered to the patients. That can be surgical, radiotherapy, and chemotherapy. Under surgery, we have wide local excision. We have primary lesion. The primary lesion can be dealt with wide local excision. If the mandible is involved, we do mandibular resection. If there is involvement of lymph nodes, we do neck dissection, that is radical neck dissection. If all these three things, that is wide local excision, mandibular resection, and neck dissection is performed, it is called as commando operation. Under wide local excision, we have three approaches. That is transoral approach. We go inside the oral cavity and perform the surgery. And another procedure is lip split incision approach, where we split the lip of the patient and access the primary lesion. Other, we have Patterson's approach, which I'll explain shortly. The other method approach, we have Weiser method, where we give an anterior curvilinear incision in the mandible, followed by raising of flap. Anterior curvilinear incision in the mandible, followed by raising of flap, and we access the primary lesion through the floor of mouth. That is Weiser approach. In mandibular resection, we have three types. That is marginal mandibulectomy, where the involved part we resect. We have segmental resection of mandible, where we resect mandible from angle of mandible to mental foramen. Then we have partial mandibulectomy, where we excise the mandible ranging from coracoid process to the mental foramen. These are the three techniques of mandibular resection. Under neck dissection, we have radical neck dissection and modified radical neck dissection, which I'll explain shortly. Under radiotherapy, we have curative radiotherapy, neoadjuvant radiotherapy, and post-operative radiotherapy. Neoadjuvant radiotherapy is given when the tumor is very large. By giving neoadjuvant radiotherapy, will reduce the size of the tumor and thereby downstage the tumor. We give post-operative radiotherapy in T3, T4 patients and N2, N3 patients. Patient with T3, T4 disease or N2, N3 disease, we give post-operative radiotherapy. The chemotherapy, we can give neoadjuvant chemotherapy along with where we downsize the tumor, or we give chemotherapy IV and orally after surgery, We can use methotrexate, cisplatin, vincristine, and bleomycin as the chemotherapeutic agents. Now, what are the surgery performed in particular state of patients? If the growth is early, without the involvement of mandible, we can just give curative radiotherapy to the patients, where we use cesium-135 needles, and we cause destruction of the small lesion. This prevents surgical excision. This prevents the surgical procedure and associated complications. Or else, we can perform wide local excision with 1 to 2 centimeter margin using Patterson's operation. What is Patterson's operation? While mentioning different approaches, I mentioned Patterson approach. The Patterson approach is we'll access the primary lesion from outside, that is from cheek. Outside, we'll raise the cheek flap. Following that, we'll excise the lesion, and then we'll place back the flap that we have raised. This is called as Patterson's operation. It is done when if the disease is early without the involvement of mandible. If disease is extensive and the growth has involved the mandible, we perform wide excision by different approaches which I have mentioned. Along with that, we'll perform marginal mandibulectomy or segmental resection of mandible. If there is lymph node involvement, we can give, if there is lymph node involvement, we'll classify into advanced disease and the lymph nodes which are mobile and not so advanced. In the mobile lymph nodes, we can perform radical neck dissection. What is radical neck dissection? Radical neck dissection is the procedure where we excise the lymph nodes from level 1 to 5, followed by excision of 3 extra lymphatic structures like accessory spinal nerve, internal jugular vein, and sternocleidomastoid muscle. Along with this, we excise tail of parotid and submandibular glands, which are the salivary glands. So in neck dissection, we perform lymph node dissection from level 1 to 5, followed by 3 extra lymphatic structure excision, that is accessory spinal nerve, internal jugular vein, and sternocleidomastoid muscle. And then we excise the salivary glands like parotid gland and submandibular gland in radical mesh dissection. If the lymph nodes are fixed, hard, and we have advanced lymph nodes disease, we can give palliative external radiotherapy. Why we can't do surgery in these patients? Because it's seen that with the patients with advanced lymph nodes, we have extensive hemorrhage on doing surgery, so we'll do palliative external radiotherapy. And also, if the lymph nodes are not involved, if the patient have only wide excision and marginal mandibulectomy, performing prophylactic block excision, that is prophylactic neck dissection, has been useful to reduce the recurrence of the disease, the carcinoma. This is all about the treatment of buccal carcinoma. Now, after resecting the tumor and mandible, we'll left with the raw area. The raw area will reconstruct using forehead flap or deltopectoral flap or deltopectoral flap to cover skin and soft tissue. The mandible that we have excised, we will place fibula graft, rib graft, or we can place prosthetic titanium to replace the defective area that we have excised in mandible. This is all about buccal mucosal carcinoma. To summarize, we saw etiopathophysiology of buccal mucosal carcinoma, which is most commonly seen in cheek. Alcohol and smoking is been the associated risk factor. Chewing betel nut, arecanut, flake lime, and tobacco. Tobacco being the highest risk for carcinoma. We have pre-malignant conditions like leukopenia, erythroplakia, and then oral submucosal fibrosis are the risk factors for buccal carcinoma. And also the chronic infection with Epstein-Barr virus, candidiasis, and HPV has been associated with buccal carcinoma. The clinical manifestations due to primary lesion, we have painless ulcer, which is gradually increasing in size. The ulcer has averted edge, indurated base, and it is non-tender. If the patient has pain, it means that the carcinoma has involved skin and is extended to mandible. And if you have referred it means that there is involvement of lingual nerve. The patient may have halitosis due to necrosis of the tumor. If the disease has involved rhabdomolar tigon, it suggests advanced disease. The spread we saw direct extension into mandible, which is presents as thickening tenderness and pathological fracture. We saw anti-gump deformity. The maxilla, if the maxilla is involved, we see external swelling. If the pterygoid muscle is involved, we see trismus in these patients. The lymph nodes, like upper deep cervical lymph nodes and submandible lymph nodes, can be involved, which are initially mobile, later becomes fixed to the underlying structure. After becoming fixed, the tumor can spread to 11th nerve, the 12th nerve, 11th nerve, and cervical sympathetic ganglion. Involvement of 12th nerve causing hypoglossal palsy and deviation of tongue to the same side, and involvement of 11th nerve causing impaired shrugging of shoulder, and involvement of cervical sympathetic ganglion causing Arnold syndrome. Next, we saw the investigation and treatment of buccal carcinoma. The investigation we saw, we perform incisional biopsy, wedge biopsy from the edge, and then we do staging during FNSE, CT, MRI, and orthopentogram. The TNM stage we saw T1, the size less than 2 centimeter, depth of invasion less than or equal to 5 mm. T2, we saw the size less than 2 centimeter, depth of invasion between 5 to 6 mm, or the size of the tumor between 2 to 4 centimeter. If the size of the tumor is more than 4 centimeter, along with depth of invasion more than 10 mm, it's T3 disease. The N we saw N0, N1, N2, and N3. Where if the ipsilateral single lymph nodes are involved, it is less than or equal to 3, it is N1. N2 is the size of lymph nodes between 3 to 6 centimeter and involvement of contralateral, ipsilateral, multiple, or contralateral lymph nodes. The N3 is lymph node size more than 6 centimeter and external nodal extension. The metastasis we saw M0 and M1. Here in M1 we see distant metastasis. In the treatment, we have different treatment modalities like wide local excision, mandibular resection, and neck dissection. The approaches we have transoral, lip split incision, Patterson's method, and Weizer's method. Radiotherapy, we have curative radiotherapy, neoadjuvant radiotherapy, and post-operative radiotherapy. In case of T3, T4 disease and N2, N3 disease, the chemotherapy we give methotrexate, cisplatin, incretin, and biomacin, IV and orally. We can give neoadjuvant chemotherapy to downsize the tumor. So, what are the surgery performed in the patients? If the growth is early and not involving mandible, we can give curative radiotherapy or wide local excision using Patterson's method. Or if the tumor has involved the mandible, we do wide local excision with marginal mandibulectomy or segmental resection of mandible, along with the lymph node dissection. If the lymph node is mobile, we do radical neck dissection. If it's advanced, we do palliative external radiotherapy. After doing the surgery, the raw surface we cover by doing reconstruction. The skin and soft tissue is covered by forehead flap or deltopectoral flap. The mandible, the gap in the mandible is covered by fibula, rib, or titanium. This is about carcinoma of buccal mucosa. Next, we are proceeding on to discuss carcinoma tongue. The carcinoma tongue, most commonly we see similar to buccal carcinoma, squamous cell carcinoma. Rarely we see adenocarcinoma and melanoma. Adenocarcinoma arises from minor salivary glands or from mucosal secreting glands. What is the etiopathyphysiology of this condition? The etiopathyphysiology is same as buccal mucosa carcinoma, that is smoking, alcohol consumption. And also we have other pre-malignant conditions leading to this condition like leukoplakia, erythroplakia, and then we have oral submucosal fibrosis and other pre-malignant condition leading on to buccal tongue carcinoma. Now, what are the sites that are involved in tongue carcinoma? Most commonly, the lateral margin of tongue is involved in 47 to 50% of patients, followed by involvement of posterior 1/3 of tongue in 20% of patients. And then we see dorsum of tongue involved in 6.5% of patients, tip of the tongue involved in 10% of patients, and also ventral surface can be involved in 9% of patients. Now, what are the types of buccal tongue carcinoma? We have classification according to gross and histopathology. According to gross, we have papillary lesions where we see finger-like projections. We can see ulcerative or ulceroproliferative type where we see ulcer, the characteristic findings of which I will mention shortly. We can see fissure type with induration, or also we can see the swelling, lobulated swelling like tongue carcinoma without any ulcer with induration. These are all the gross types, that is papillary, ulcerative, fissured, and lobulated type. On histopathology, we already discussed we have three types, that is squamous cell carcinoma, adenocarcinoma, and melanoma. Now, what are the clinical manifestation of tongue carcinoma? Under clinical manifestation, we have primary lesion, which can be painless ulcer or a swelling, similar to buccal mucosa carcinoma. If the lesion becomes painful, it means that it has involved lingual nerve. We can have referred otorrhea due to this, or due to secondary infections, we can have pain in these patients. The ulcer seen in carcinoma of tongue is having everted edge, it has indurated base, and it bleeds on touch, same as carcinoma of buccal mucosa. We can have halitosis due to necrosis, which releases ammonia, butyric acid, and mercaptone. Also, in carcinoma of tongue, due to the secondary infection of this lesion, following trickling of secretion, we can have bronchopneumonia in these patients. We see spread, the local spread to the surrounding tissue. The tumor involving anterior one-third of tongue will commonly spread to genioglossus muscle, which causes dysphagia. The spread to other tongue muscles can cause difficulty in protruding the tongue, called as ankyloglossia. And also anterior one-third, the tumor in the anterior one-third of tongue can spread to mandible, causing mandibular involvement. The involvement of tongue muscles causes difficulty in articulating the words. The tumor in posterior one-third of tongue, it's adjacent to tonsil, it can spread to it. It's adjacent to pharynx, it can spread to it. And it can spread downwards to involve larynx. It can also spread posteriorly to involve cervical spine. This is about the local spread. We have lymph node spread. The lymph nodes are initially mobile. Later, they become hard and nodular and fixed to the surrounding structure. The lymphatic spread is from the tip of the tongue. The lymphatic spread is to submental lymph nodes. From the lateral aspect of the tongue, the lymphatic spread is to submandibular lymph nodes and to upper deep cervical lymph nodes. From the posterior part of the tongue, the lymphatic spread is to pharyngeal group of lymph nodes. This node, the submandibular group of lymph nodes found in tip of tongue, also drains to contralateral lymph nodes, causing bilateral spread. And also, the central part of anterior two-third of tongue will spread to contralateral, submandibular, and upper deep cervical lymph nodes. So thereby, bilateral lymphatic spread is common in case of tongue carcinoma. Now, how do we manage these patients? We have investigation and treatment. Under investigation, we perform wedge biopsy, where we see the keratin pearls and malignant cells. We can do FNAC of lymph nodes to see the involvement of lymph nodes. We can do direct or indirect laryngoscopy to look for spread to larynx. We can do MRI and CT scan to look for extent of local disease and lymph node involvement. And also, we should do chest X-ray to look whether the patient has bronchopneumonia. We can do orthopentogram to look for mandibular involvement. Now, how do we treat these patients? We have three modalities, that is surgical treatment, radiotherapy, and chemotherapy. Coming to surgical treatment, the primary lesion, that is lesion in the tongue, if it is less than 1 centimeter size, we perform wide local excision with 1 centimeter margin. With 1 centimeter margin, we perform wide local excision. If the tumor is between 1 to 2 centimeter, we perform wide local excision with 2 centimeter margin. If the lesion is more than 2 centimeter, we perform hemiglossectomy, that is the resection of half of tongue from tip of tongue to the sulcus terminalis. All of the half of the tongue will remove if the lesion is more than 2 centimeter. Following that, we are left with the defect, which we will close by pectoralis major myocutaneous flap, or we can also do quilled skin split screen grafting. What is quilled split screen grafting? Along with placement of split screen graft here, we will fix this graft into the surrounding tissue by using interrupted suture, that is called as quilled split screen grafting. Now, if there is spread to the mandible, we perform mandibulectomy, whether it is marginal or segmental mandibular resection. Now, lymph nodes spread, if we have, we perform radical neck dissection. If it is unilateral spread, that is involving ipsilateral lymph nodes, we perform radical neck dissection, the components of which we saw when we discussed buccal carcinoma, mucosa carcinoma. If we have bilateral lymph nodes positivity, for ipsilateral lymph nodes, we will perform radical lymph node dissection, and for contralateral lymph nodes, we will perform modified radical lymph node dissection. We saw in radical lymph node dissection, we perform the dissection of level 1 to 5 lymph nodes along with 3 extra lymphatic structures like accessory spinal lobe, internal jugular vein, and also sternocleidomastoid muscle, along with tip of parotid gland and submandibular gland. In case of modified radical neck dissection, we perform level 1 to 5 lymph node dissection. Along with that, we spare any one of these extra lymphatic structures. Any one is preserved. Usually, we preserve internal jugular vein so that the cerebral perfusion is adequately maintained. Now we see radiotherapy. Under radiotherapy, we have neoadjuvant radiotherapy to downsize the tumor. We have small, if the lesion is very small, less than 1 centimeter, we can give curative radiotherapy similar to that of buccal carcinoma. We have post-operative chemotherapy in this patient. We have Prince Hill regimen, where we give methotrexate, vincristine, adriamycin, and bleomycin, along with mercaptopurine. Chemotherapeutic agents, if we observe, for buccal carcinoma of buccal mucosa, we give methotrexate, adriamycin, bleomycin, vincristine, along with cisplatin. Here we change cisplatin to mercaptopurine. That's it. So this is all about the carcinoma of tongue, where we saw the etiopathophysiology of this condition, that is similar to carcinoma of buccal mucosa, that is smoking, alcohol, pre-malignant conditional leukoplakia, erythroplakia, and oral submucosal fibrosis. Most commonly, we saw involvement of lateral margin in 47 to 50% of patients, followed by involvement of posterior 1/3 of tongue in 20% of patients. Now, types, we have gross types and histopathological types. Under gross, we have papillary type, ulcerative type, fissured type, and lobulated type. Under histopathological type, we have squamous cell carcinoma, adenocarcinoma, and melanoma. Then we saw the primary lesion, which can be ulcer or swelling. It is usually painless. If it is painful, it indicates involvement of lingual nerve and secondary infection. The ulcer is having everted edge, indurate, and the base is indurated, and it bleeds on touch. We have excessive salivation in these patients due to this ulcer and swelling. If we see halitosis, it's due to necrosis of the lesion, which releases ammonia, butyric acid, and mercaptone. And also, if the tumor involves posterior 1/3 of the tongue, the patient may complain of pain on swallowing, vodinophagia. C, spread, that is local spread and lymphatic spread. The local spread in case of anterior one-third of tongue will cause dysphagia if it involves genioglossus muscle. The involvement of other tongue muscles causes ankyloglossus, which causes difficulty in articulating words. The involvement of posterior one-third of tongue causes spread to tonsils, pharynx, larynx, and cervical spine. The lymph node spread we saw, it spread to submental lymph node, submandibular lymph node, upper deep cervical lymph nodes, and pharyngeal group of lymph nodes. We saw tip as bilateral spread to contralateral one, and also central part of anterior one-third of tongue will also spread to contralateral lymph nodes. The management we saw investigation, wedge biopsy, FNSC, direct indirect laryngoscopy, MRI, CT scan, chest X-ray, and orthopentogram. And the treatment we saw surgical excision, that is wide local excision. If it is less than 1 centimeter, we perform wide local excision with 1 centimeter margin. If it is more than 2 centimeter, between 1 to 2 centimeter, we perform wide local excision with 2 centimeter margin. And if it is more than 2 centimeter, we perform hemiglossectomy. The lymph nodes we saw, if it is ipsilateral lymph node involvement, we do radical lymph node dissection of that side. If it is bilateral involvement, the ipsilateral side we do radical lymph node dissection, and contralateral side we do modified radical lymph node dissection. Radiotherapy we saw radioadjuvant and small, if the lesion small, we give curative radiotherapy. Chemotherapy we have one regimen called as Prince Hill regimen, where you methotrexate, vincristine, adriamycin, bleomycin, and mercaptopurine. This is all about carcinoma of tongue.